From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. Individuals with atopic dermatitis are frequently colonized and infected with Staphylococcus aureus. Empiric antibiotic therapy is common, but data about the antimicrobial susceptibility profiles of Staph aureus strains isolated from these individuals in particular geographic locations are scarce. In a new study in JAMA Dermatology, authors performed a meta-analysis of the literature to determine the antimicrobial susceptibility of Staph aureus for individuals with atopic dermatitis. Authors also analyzed differences according to income level of country of origin and data collection period. Dr. Maria Teresa García-Romero is a board-certified dermatologist, pediatric dermatologist, and investigator at the National Institute of Pediatrics in Mexico City, Mexico. She's an associate professor at the National Autonomous University of Mexico. She's also one of our inaugural JAMA Dermatology editorial fellows. And she's the senior and corresponding author of this new article and is here to discuss this work and potential implications on clinical practice. Welcome to the podcast, Dr. García-Romero.
Oh, thank you, Ade. Very happy to be here.
All right. So could you please let the audience know about your role at the National Institutes of Pediatrics?
Sure. So the National Institute for Pediatrics in Mexico City, Instituto Nacional de Pediatría, is a government hospital for patients with no kind of insurance whatsoever. We only see pediatric patients. And I do clinics. I do about 50% clinical and 50% research activities. We have pediatric residents and we have pediatric dermatology fellows training with us. We have some subspecialty clinics like vascular anomalies and epidermolysis bullosa clinics.
So because you're a pediatric dermatologist, it's pretty clear, probably to the audience, that you deal with a lot of atopic dermatitis. And I'm assuming this is the reason for you wanting to study this specific subject of antibiotic susceptibility. Is that true? Or were there experiences that you can think of in the clinic that made you want to specifically study this topic related to antimicrobial susceptibility of Staph aureus?
Sure. We do see a lot of atopic dermatitis. And we usually follow international guidelines, right? So like the ITSA guidelines and other infectious disease societies. And I've always thought that's odd because we surely have different antimicrobial susceptibility patterns than other countries. But I think the first time that I thought about doing this work was after we finished a longitudinal study that we did with Dr. Tammy Lieberman's group at MIT a few years back, where we tracked patients with atopic dermatitis longitudinally and obtained samples not only for 16S sequencing to study their microbiome, but we also took some Staph aureus cultures. And we found that most patients had Staph aureus colonizing their skin as expected. And as we analyzed the adaptive evolution of these isolates, we found that some patients had a new capsule-associated gene mutation that had not been reported before. And this mutation probably gives Staph aureus some kind of advantage in the skin that it's colonizing in patients with AD. So we started looking further into virulence factors and mechanisms that the bacteria has to evade host immune response. And that led to the question of, well, we should first of all see what antimicrobial susceptibility patterns these isolates have. And further on, we started studying how much biofilm these isolates have. So these isolates of Staph aureus from children with atopic dermatitis. And so as we started reviewing the literature, I eventually thought what would be even more interesting would be to contrast these susceptibility patterns across time and world regions. And so for that kind of analysis, we got in touch with Neri and Fernando, two of the authors who work at the Autonomous University of Nuevo León, which is in the north of the country. And they have a Mayo Clinic partnership. They have a care center for evidence-based medicine. So they have all the training and the infrastructure to conduct systematic reviews and meta-analysis. And well, the rest is history. We started
working together, and you drew up your plans to investigate the literature from inception until I believe it was 2023, looking for studies across the literature that examined antimicrobial susceptibility patterns of Staph aureus. The literature is probably very broad as it relates to susceptibility patterns. How were you able to kind of restrict your searches so that you could get a somewhat representative sample of the diversity across the globe? Put another way, how did you design the inclusion-exclusion criteria in this meta-analysis?
Okay, so first of all, we restricted the languages to English, Spanish, French, or German, just because those are the languages that we spoke or were able to understand and translate. So based on the languages, we did have to exclude some articles. At second, we needed studies that reported antimicrobial susceptibility profiles of at least one Staph aureus cutaneous isolate from individuals with atopic dermatitis, regardless of age, sex, ethnicity. Some of the studies included data on healthy control. So we, of course, only extracted the information pertaining to patients or individuals with atopic dermatitis. But then also, as we were reviewing the articles, we encountered other situations. And so articles where they did not allow us to calculate the prevalence of the resistance to a certain antibiotic because they did not give us enough data to do that, we also had to exclude. And also articles where they, for example, reported data of cutaneous isolates mixed with other type of isolates, so blood or, I don't know, some kind of internal wound, etc.
And you also set up a pre-planned sub-analysis that I thought was quite interesting. You want to tell the audience a bit about why you did this sub-analysis?
Yes, so the pre-planned sub-analysis included studying differences between world regions. And so we had to decide whether we should do world regions as in continents or geographical regions. And we decided that probably the best categories were the World Bank income groups. So low income, low middle income, upper middle income, and high income countries.
Why did you decide to do that versus, let's say, Southeast Asia or North America or South America? What was the idea around that?
So the idea was that, for example, let's take North America. So North America includes Canada, the United States, and Mexico. But there's a lot of difference between Canada and the United States and Mexico. So it made sense to use the income classification because really income is what dictates a lot of the country's abilities to control healthcare access, even the medications that are available, right? So it's not the same. It's very different to think of a healthcare setting in the US than in Mexico. And it's entirely different to think of a healthcare setting in Argentina versus probably, I don't know, Venezuela, right? And they are in the same geographic region.
Right. And then your other pre-planned analysis was looking at heterogeneity among different periods And it looks like you had 3 periods. One was before 1985 to 1997. The other one was 1998 to 2010. And then your last period was from 2012 to 2023.
Right. So we also wanted to analyze trends of antimicrobial susceptibility. That made total sense to me because some antibiotics were reported and used for colonization of patients with atopic dermatitis or superinfections in these populations, and they're no longer used like erythromycin. So it's very logical to think that trends of susceptibility profiles have changed along with trends of usage.
That does make sense. But before we get into the results, what did you think going in this analysis that you were going to find? Did you think that you were going to find a lot of heterogeneity as it relates to microbial resistance? Did you think that it would be high-income countries versus low-income countries that may have more resistance? What did you think was going to result from accumulating all of these different studies together in one place?
So we did expect high heterogeneity just because studies were completely different. So some studies were trialing a medication, no? For example, a topical fusidic acid, or as I said, erythromycin for patients with atopic dermatitis in 1980s or something like that. And other studies were more epidemiological, so they were trying to obtain these data from their populations. And other studies were really more into the microbiological side. So they were really studying other characteristics of Staphylococcus aureus, but additionally reported some antimicrobial susceptibility profiles. So we did expect very high heterogeneity. In terms of the results, I did expect to see a significant difference according to the publication or the data collection periods of the studies. And I also definitely expected to find differences according to countries. I somewhat differed from what I was expecting and from what we found because, for example, methicillin resistance, I expected it to be higher in high-income countries, as has been reported in some studies. But there's also the definite fact that antibiotics are used more widely and with less control in countries with lower incomes. So could expect to find a higher methicillin resistance in high-income countries, but at the same time, we weren't that sure what we would find.
Yeah, probably because a lot of the heterogeneity. So not to keep the audience in the dark for so long, what were the results? What were the overall prevalence of antimicrobial susceptibility that you found? This is the high-level results.
Okay, so we included 61 studies. These studies reported over 4,000 Staph aureus isolates from over 5,000 individuals with atopic dermatitis. And we had to restrict our findings and our focus of the study to the commonly used antibiotics. So the ones that are reported in guidelines and articles and expert opinions to use in patients with atopic dermatitis that have flares or get super infections. So we set our focus on 11 commonly used antibiotics. Of these 11 antibiotics, 4 had antimicrobial susceptibility of 85% or less, including methicillin, erythromycin, fusidic acid, and clindamycin. And except for erythromycin, which is not that commonly used anymore, all the others are commonly used in patients with atopic dermatitis.
That's concerning, right? Because you want your susceptibility to be much better than that number.
For sure. And that's another very interesting question, which is the threshold to decide whether an antibiotic should be used or not anymore. And we actually had a lot of trouble finding literature regarding this particular topic. But there are some very interesting studies suggesting that the threshold should be 85%. And it is for clindamycin, for example, and even for methicillin.
Right. So you also showed that there were some optimal susceptibility rates for some other antibiotics. Which ones were those? So ones in which perhaps clinicians should consider first line in empirically treating patients that may have Staph aureus causing a flare of their atopic dermatitis.
So, for example, well, of course, vancomycin, although this is not an antibiotic that would be used in the community.
Yeah, you don't want to use that in the clinic.
Of course not. But others that could certainly be used are trimethoprim and sulfamethoxazole, which is an antibiotic that we don't use that much anymore, particularly because of side effects. I think we're all a little bit afraid of adverse drug reactions that may be severe. So others like doxycycline, daptomycin, and minocycline had very high susceptibility rates, although there were much lower numbers of studies that reported them. And finally, mupirocin had a very high antimicrobial susceptibility, and it's a topical antibiotic that we use commonly for less severe infections, superficial infections. And linezolid, although we would not be using linezolid in the clinic either.
And so in your subgroup analysis, what did you find? I'm particularly interested in the subgroup analysis by income level of country, because it seems like that sort of surprised you, those results.
Yeah, so first of all, most studies, so 47 of 61 studies were from high income countries. So I would say that is the first thing that gets your attention, right? Like there's very scarce data from middle income countries, and we actually could not find any from low income countries. Stunning, right? So I think that alone is something to take home and think about.
Why do you think that's the case? I mean, I think there's the obvious, some of these countries don't have the infrastructure to do population-based epidemiologic susceptibility study for this particular disorder. Or perhaps language was an issue. Maybe some of these countries, English, German, or Spanish, or the other languages that met inclusion criteria just are not spoken there. And perhaps that's the reason. Do you agree?
Yes. So, as most things in the world or in the current world we live in, resources, money is everything, right? So, if you're a low income country, you're struggling to meet basic demands of your population. So, one, there's no money for research, and doing research takes money, even by paying someone to go and collect this data and publish it. And number two, as you say, publishing in a English speaking journal also takes money for people who don't speak English as a native or as a second language. Because if you don't have adequate formatting, editing, grammar, syntaxes, then you're not going to be published in a high impact journal in English, even if your data is very good. So it's like a self-fulfilling prophecy. So that was, we kind of expected it, but it certainly was stunning to see that there were none.
That's concerning. And then for the subgroup analysis related to temporal trends, it looked like there were no differences over time.
No, there were no significant differences, which was also surprising. I would have expected to find some antibiotics with increasing resistance rates across time, but no, we did not find this.
So to kind of wrap up here, what is the take-home point for physicians after reading the study? Should they change how they approach treating individuals with atopic dermatitis that have Staph aureus, their colonization or superinfection?
So I think there's a couple of take-home messages. One is, as with any infectious processes, always, if possible, make individual patient decisions. So take a swab, send for culture, maybe start antibiotic treatment according to guidelines, but then change it accordingly. So that would be number one take-home message. The number two take-home message is the absolute necessity of generation of local and regional data and guidelines, because as we said, if we follow US or European guidelines here in Mexico, and we shouldn't be doing that. We should be generating our local guidelines according to our local data and also the antibiotics that we have available. And the final take-home message, more in a public health aspect, would be that countries with less resources need support from international global organizations in order to, number one, obtain their local data on antimicrobial susceptibility patterns, not only in atopic dermatitis, in all infectious processes, and be able to have it out there, right? Even for their local community of healthcare providers to know and to be able to take that information and make decisions.
I'm Dr. Adewole Adamson, and I've been speaking with Dr. Maria Teresa García-Romero about global antimicrobial susceptibility patterns of Staph aureus and atopic dermatitis. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening. Catch you on the next episode of the JAMA Dermatology podcast.